Hey there, this is Mackenzie Herkin doing my final presentation for delivery of care in the healthcare environment. So just a quick overview of the current healthcare service delivery system and the influences that are along with it. Our cost, we have an increase in cost for pharmaceuticals, for healthcare coverage in general, the cost of care for services delivered and procedures and treatments, and increased duration of illness such as chronic conditions. So we have more people having more chronic conditions for longer periods of time, which are creating a cost deficit for the system. Access is always a hot topic. We have general access issues, which is the ability to pay for care but opt out or cannot obtain care. We have special access issues, which is the inability to get care related to distance, income, or ability. We have a disparity in health levels and outcomes. Currently, we aren't getting what we pay for. Cost doesn't correlate to quality. Currently, the United States ranks very low compared to other more developed countries as far as our health levels and outcomes go. So we're paying the most for our healthcare, and we're getting some of the poorest quality from it. Economic factors that influence our healthcare are insurance is currently tied heavily to jobs and expendable income. And you have to have expendable income anymore to afford healthcare and healthcare coverage and to pay for services. We have increased costs of medical services in general and the sustained need for those services from illnesses like heart disease and diabetes, those chronic illnesses. We have utilization of service, focus on money and not needs. So, as we're moving to a more value-based system from a fee-for system, we were very much geared towards productivity and production, not necessarily the quality that was tied to any of those actions. So the fee-for-service really has inflated our costs that come with healthcare because we were ordering unnecessary things and we're duplicating services and everybody's kind of got to have their piece of the pie and they want more pieces. Legal issues that go along with our healthcare system right now are compliance, and it's time consuming and costly to adjust and maintain compliance with our reforms such that come along with the PPACA and digital records and documentation of all those metrics and those benchmark data that we're trying to do. It takes time to educate people on those, and then it takes a certain amount or a significant amount of legalities and regulations to be compliant and to maintain those security measures for the healthcare services that we're doing. Political factors or policies and laws that influence how healthcare operates is funded and reimbursed and dictates our practice. So there's a lot of legislation and political factors that go into how we deliver care and how we bill for care and who is even entitled to care. The Patient Protection and Affordable Care Act. The CARE Act represents an effort to reframe the financial relationship between Americans and the healthcare system to stem the health insurance crisis that's enveloped individuals, families, communities, and the healthcare system, as well as the national economy as a whole. It works to secure the access and availability of coverage for more of the population and reforms insurance practices to ensure that more people have access and lowers the barriers, such as for previous existing conditions. Its focus is to expand access and improve quality, lift eligibility restrictions, and decrease cost, promote wellness through prevention. Is it working? Since the ACA's first open enrollment period in the fall of 2013, the number of uninsured Americans has fallen from 41 million to 27 million. So that seems to be working. The leadership and own competencies that go along with healthcare and change in the delivery of healthcare are communication and relationship management, knowledge of the healthcare environment, professionalism, business skills, and leadership. So these competencies are what all come together to ensure that we as nurse leaders have the skills and the acumen to be those change advocates and to be competent in advocating for these delivery practice changes and ensuring that we have evidence-based practices that are promoting quality outcomes as we transition from that fee-for-service system to a value-based driven system of healthcare delivery. Models of healthcare delivery are patient-centered, that I chose, were patient-centered medical home and the affordable care organizations. So these are both very similar. For patient-centered medical homes, we are patient-centric. We provide engagement and care of the patient. We provide provider accountability, improve communication, collaboration, and access between all parties, and reduction in the unnecessary or already completed treatments and procedures. So we're decreasing the waste that comes with having this fragmented and disjointed care in our healthcare system by having a whole team that is pretty well involved with every facet of your care. So they are more apt to know what's going on with you. You're more apt to have an open dialogue and honest discussions and have your needs better met as well as better managed. The disadvantages to this are that it's a big investment to restructure and learn new processes. Currently, we don't really have a team-centered approach to things, so it would take a little bit of time and effort to readjust our thinking and expand those leadership roles. So this care model exemplifies the nursing meta paradigm of treating the whole person and all the factors that surround the patient. Models of healthcare delivery, patient-centered medical home and Affordable Care Act, care organizations. The Affordable Care Organization is very much like the patient-centered medical home. It limits cost risk to patients. It's quality, not fee-driven. It incentivizes for quality outcomes, and it decreases waste in time and services, much like the patient-centered medical home. It is also provider-driven, and it improves communication and collaboration and focuses on positive outcomes. The disadvantages with this, again, are that it needs universal language to assess outcome metrics accurately. Another disadvantage of the ACOs is that, as with anything new, it requires time and money to implement and monitor. And we kind of have poor buy-in at this time for reimbursements aren't clearly defined at this time, and so providers don't really have clear metrics of what they'll be reimbursed for the work that they're doing. They also are somewhat reluctant to buy in because, you know, they're so ingrained for productivity that they're not really seeing the value of taking longer to see patients and working for those better outcomes when they don't actually have clearly defined reimbursement practices and you know, evidence that really supports that this is working and benefits them. So the nursing theory that I chose to go with my choose and delivery care model of the patient-centered medical home for the research paper, or for the paper that we did, is Goal Attainment by Imogene King. According to King, a human being refers to a social being who is rational and sentient. He or she has the ability to perceive, think, feel, and choose, set goals, select means to achieve goals, and make decisions. He or she has 3 fundamental needs: the need for health information when it's needed and can be used, the need for care that seeks to prevent illness, and the need for care when he or she is unable to help him or herself. It's my belief that this theory best supports the PCMH and embodies the nursing paradigm because it focuses on engaging the patient and empowering quality care through inclusive decision making. Her focus on preventative care also falls in line with the patient-centered medical home and the Affordable Care Act's provisions. The pursuit of quality care and moving forward, we have the IOM's 10 rules of redesign, all of which are embodied in the patient-centered medical home. Through that patient-centered relationship that's built in the PCMH, you are focusing on that healing relationship of the patient and building relationships. You do have to tailor and customize that towards the patient's needs and values. That's the whole point of having a team to provide care, so you can encompass that whole being. The patient is obviously a source of control because they're the ones empowered in their care, being aided to make decisions, given the best information possible so that they can make informed decisions. Knowledge is instrumental in the patient-centered medical home, as is communication and collaboration. Decision-making is obviously paramount. Transparency is built with that relationship between providers and patients, the community. Waste is continuously decreased. Like I said, with patient-centered medical home, everybody working as a team and everybody building that relationship with the patients, they will know what's going on with that patient, and that reduces duplication and waste in services and treatments that are being provided. The elements of the patient-centered medical home, inquiry, analysis, and action, all work together. Inquiry is very simple to be implemented in the patient-centered medical home. As you build that relationship with your patients, you're able to have that dialogue to answer the questions that are needed to gain a database of information that you can then analyze and pull information out of. Being a part of the patient-centered medical home allows the boots on the ground, the people at the front line that are working with the public and those patients, to correlate different data metrics that are pulled with specific information or just information that they've gathered, seen, or know to be true, so that they can have a more wholesome idea of what problems might be and why they might be that way. They have a more informed idea and process, kind of more intimate knowledge of their patient demographic and their patient population's whole backstory and social determinants and stuff, so they can help notice trends and identify areas of improvement and how to do so. The culmination of my report is that in order for the United States to stop the cycle of rising costs and poor healthcare, there needs to be significant reform and a mind shift of priorities and actions. The PPACA is attempting to address this, and by all accounts has made drastic improvements in expanding coverage, access, and affordability. We still need to push for quality care that rewards value and outcomes over productivity. And this is one way that the PPACA is blazing towards change and improving population health. However, this system takes time to establish and can be difficult to navigate. It requires considerable time, money, and education, as well as data to check that the data we're gathering is gathered appropriately. So we kind of have to invest in that universal language as well, so that everybody's checking the same boxes and using the same terminology, so we're accurately comparing apples to apples and not apples to oranges. The patient-centered medical home fits great with all that the PPACA is trying to accomplish and has the potential to support great improvements in healthcare. So with any luck, as we continue to push for this value-driven system and we start implementing new delivery care models that are more encompassing of the patient and quality of valuable outcomes, hopefully we'll get where we're going, or get where we need to be. It just seems at this point like it's going to take a fair amount of time. Here are my references, and I'll address the elephant in the room. I currently don't have internet at home or anything, so I have internet in my vehicle for the time being, and so that's why I am doing this presentation from the car. I understand it's not super professional, but I hope that you guys see it as innovative in getting things done. Like I said, it's been a great class having this course with all you guys. It's been great. I hope you guys all go on to do great things. This is my last course, so I won't be seeing you again, but maybe we'll see each other professionally down the road. Thanks, and have a great 4th of July, everyone.